Na hizi zingine chana depression. Okay, depression can be there. But tunakwanga tumejilabel mazi. Siku hizi. Some 50-year-old man. So my ADHD does not allow me to watch all these videos. So my OCD today. So my anxiety today, I was just...
ADHD is another overdiagnosis. You're having attention difficulties for something else. You just... you have other distractions in your life that are impairing your attention. You're like, my ADHD, and you have other things that, are really interfering with your ability to focus and probably...
mi naonanga tu ni kama ni jokers pale social media kuna ADHD.
There are some who are legit, but there are also some who are, and it's interesting because I also do telepsychiatry. So I've been getting a lot of consultations for people who want to know, do I have ADHD? And many a times for those who reach out for help, I think let me speak for myself. The ones I've seen, about 80% would be accurate that yes, this actually ADHD. Right.
Adults?
Yes. Because what happens a lot of times... Right. I think now the world is becoming more aware. But during our childhood times, you have symptoms when kichwa ngumu, and you'll be beaten thoroughly. Yes, you're beaten thoroughly because you don't do homework, you don't follow rules, and you were just labeled as a difficult child when indeed there was a problem. So what happens now? You're an employed worker and you're still having attention difficulties. You've never been able to actually figure out those symptoms and get help for those symptoms, and they're now following you to adulthood. So yes, there are those who get diagnosed in adulthood, and especially when they're having difficulty in sustaining a job or having difficulty in relationships, just basically their functionality, when they get diagnosed. But then you get somewhere like, I have ADHD, and you do an assessment and you're like, no, I don't think you have ADHD. They're like, no, I have ADHD. And you're like, okay. Wow.
So what do you do in that situation?
No, you just give your information as is. Most of the time you'll find they'll be upset. They'll go and look for another doctor to try and...
Who will tell them, who will affirm their diagnosis.
Because some of them are just trying to get ADHD medications, which are stimulants, and they increase focus and all that. But do you really need these medications? Probably not. And when we have people being diagnosed who don't need, we end up having like rationing of the drug. There was a time the drug was out of stock for almost...
In Kenya?
Yeah.
I think it was
earlier this year or something. And then that now destabilizes those who actually need this drug. Yeah.
But is it a prescription only?
Very prescription only.
Na inaendaje out of stock?
Hiyo hata ni ile prescription only ya what DDAs, the ones that you can't get. Ile si prescription mwitu, like it has to be a proper prescription.
Na hizi zingine ma OCD.
I rarely ever diagnose OCD. That one, I'll be honest. It's those once in a while.
But people like, mtu akiona yeye ni msafi sana, OCD. Unavaa style kila siku, OCD.
I think one thing, we label...
Those labels.
There's so many labels,
Do you think people...
You go through an experience, someone says, mi niko na PTSD, I'm traumatized. We label a lot.
Are we... Is the current generation, maybe millennials and Gen Z, do they enjoy those labels or something? Or is it just a way of identifying or something?
I think it's an awakening that is also coming to being. People are like, okay, actually these are symptoms of depression. I'm feeling low. I
So
could be depressed. Okay. So, because this is like the mental health age coming to life, before our parents... mental age was still a taboo and all that. Yes, but people call these things lightly, but the people who actually have depression will tell you it's more than just one sad day where you're feeling like I'm feeling low because my boyfriend didn't send me money or something like
And
that.
you will not be vlogging about it.
And you'll not be vlogging about. Highly unlikely you'll be vlogging about
Yeah,
it.
yeah.
There are people who would, but for the better part of it,
They will not.
yeah, you'll not be vlogging about it.
So you see a lot of this?
What?
Those amejilebo.
Yes. Now, people call they want and I don't know what. I don't know if there's. I'm here to find out what the incentive is because there are people who actually insist on being given a diagnosis, and you're like, okay,
You're just okay.
you're not.
Yeah.
Yeah, like there's a patient I saw, and I informed the. They didn't have the diagnosis. I thought. I mean, they were seeking help for. I told them, you have a lot of challenges. It doesn't mean that everything is okay. There's still something wrong. But you have a lot of challenges which we can work through. 1, 2, 3, 4.
No.
No.
Ashakuja na diagnosis.
Shakuja na diagnosis.
Unajua hata si mental health peke yake. Even in the outpatient setups, just see a patient, and some of these I usually think probably there's a mental issue, yeah? Because anakuja tu, daktari uchungu inaanzia hapa, alafu inapiga kona, inakuja huku, ina zigzag hapa kidogo, alafu inarudi. You're like, are you trying to be sick? You know, you're okay.
Yeah. And the weird part is for the longest while, people would fake headaches, stomachaches. No one would fake a mental illness, but nowadays
people
people would run away from a mental health diagnosis. Even just being told you have depression. But nowadays people are ready to embrace it. In fact, they want it and they don't have it. I have autism.
Exactly.
Like, okay.
That's the other thing I wanted to talk about. Autism. Our parents, because I've seen, I mean, you take a history from a parent, and they're telling you, this baby, when they were born, they didn't cry immediately. So this is, a palsy of some grade, yeah? But they're like, no, my child is on the spectrum. My child is autistic. And they insist, and I think also some healthcare workers get it. Because now we have so many people saying they have autism.
They have autism.
When it's actually not. I don't know, as a psychiatrist,
I don't know, but normally they say the mother is usually the first doctor. So there's usually some aspect to that. But then now we're also moving towards an age where people are ready to, quickly label things before. Because one thing we normally say is, you may come to me for the first consultation, and we don't come to a conclusive diagnosis of what is going on. We can say, yes, there's actually something going on.
But will take time.
But it may take time to actually pinpoint what exactly. There are those who will come and it's spot diagnosis. You're like, this one, mania. There's no...
There's no in between.
There's no in between. This is mania, But then there are some who will come and there's a lot of, overlapping issues, overlapping symptoms. And it might actually take you maybe 2 or 3 consultation sessions to figure out what is the exact diagnosis. So in such cases, we try to, could we do another session? And you can also offer them the opportunity to have a session with a different professional as well. Because some may feel you're denying them
a diagnosis.
And some people want diagnosis so that they can also go and register for disability. So that they don't pay taxes.
Why? Wisdom.
Wisdom.
Kwa hiyo maneno hata mimi sijui nichukue gani.
Wewe. Yeah, so I learned that's a new thing I learned. People are coming for, so that they can...
But kuna hii pia, I think the Hollywood, the movies, like this movie, The Good Doctor. The lead actor, the stereo, is purportedly autistic, and is this amazing doctor. So people have seen it, and if your child is not following the norm, you want them to be that.
Yes,
probably in the hope that they'll be a genius later.
So we're idolizing.
We're idolizing that. I mean, in your experience, or maybe reading, is there autism that goes that way? Is it just theoretical or real autism, and then unakuwa genius? Is that possible?
One thing about autistic kids is they have usually have at least I want to call it a superpower, but like a key interest in something. Some you'll find it's music, and they're really, really
really
amazing at it. You know, more than you who can, you know, conceptualize things a bit better. So we do have, and why it stopped being called autism by itself is because there are children who are on the spectrum.
Yeah, they're somewhere along it.
Somewhere. So they're from the mild to the very severe autism. We also have something called Asperger's, which is like it's been a milder version. Yeah, and those ones, just function normally in society, but there's usually just something. There's something off that's just not right with them, or they have this repetitive behaviors or these repetitive routines. So I wouldn't dismiss a mother very quickly when she says her child is autistic. Okay, so the question may be, okay, maybe it's not autism after you listen to the story, but I mean, by the time she's coming, there's something that's not, there's something that's not right. And now what is it exactly that we're dealing with?
But the cool diagnosis is autism. That's the nice
I don't know
one.
how that's a cool diagnosis.
You know, cerebral
yet to
palsy,
understand.
autism. I mean, autism sounds nicer.
I think because also of, we know we've had a lot of mental health champions, and it's looking like the vibe,
it's what's up, it's what's popping.
You know, it's what is trending, you know, but really getting a diagnosis and getting treatment for a disorder that you don't have, usually it's a disservice to you and to the system as well.
Okay. You've mentioned drugs, umeongelea, sijasikia ukiongelea drugs sana when it comes to treatment. You said maybe for depression, give them medication. What's the role of talking?
Therapy, very important.
Because there's been an accusation now here. There's been accusations that psychiatrists anakuona unakuwa kwa mlango depression clock setting. Unapewa dawa.
That's partly true and partly false. Okay. Why it's partly true is a number of people wait until the disorder is so severe. So you've been prayed for, you've taken 2 years, 3 years, 5 years at the counselor's office. You're not improving, but you're still going there. You know, and it's, you know, continuous. But so by the time you're coming, you know, some are even taken to the forest to be prayed for and have some time alone, poured on water, you know, on all manner of activities that can happen. So by the time they come, they're already having like a severe illness. What will happen? The first line of treatment will be medication. Yes. So
hakuna wale wa mild kuna.
So that's what I was saying, partly true. And partly
so that's the
not.
true part.
Yes, that's the true part, because a lot, for the longest time, I think people are now embracing seeing psychiatrists. Before, psychiatrist was like, you know, when you tell someone, have you seen a psychiatrist? They're like, hajafikia hapo. You know, it was always thought that by the time you're seeing a psychiatrist,
it has to be
something really bad, really severe. So, and if you're going to wait to see a psychiatrist when things have gotten severe, chances are you are going to get medication.
Or you wait until you're now admitted. Or you've been brought.
Or you're now suicidal, and we are thinking of more extensive measures, ECT and all that. So yes, it's partly true because of that. That has been the trend, but then it's also not true, because if I see you as a psychiatrist and I see you have mild depression, I mean, the first line of treatment for me would be send you for therapy. Yes.
And it works? We usually say, we are Africans, bana. Therapy nini? Bana, therapy.
Now, to talk about therapy. It's good the Kenya Counselors and Psychologists Board came on board to regulate and, you know, the practice. Because people who are going, they do a 3-week course, like, I'm a counselor. You know, mimi, you know, I am mental health, you know.
Wale wa high school, teachers wamefanya some course.
Yes. So we were having
counselors.
Yes. I don't know why they used to do that. Mwalimu wa CRE was the default
counselor.
guiding and counselor
Yeah.
teacher. So for the better part, we've had a lot of rogue people out there managing, unqualified people managing patients.
Yeah.
All right. So a patient comes to you and you think, oh, therapy is just talking. In fact, they go and they give you advice. And they tell you, so nini naendelea? Okay, so your partner has been cheating. What has been happening? And they listen and they listen, and then after that they tell you, now this is what you will do.
Oh.
Okay, this is what you'll forgive. You will go back to the house. You will cook for him.
Ala.
You know,
Huyo ni therapist.
huyo ni mtu anajiita therapist, anakupea advice. Okay, because they have not gone through the school of training to know how to manage a session. Now, there's still the role of counseling where listening. There are patients who just want to be listened to. There are patients who, from time to time, may want, or other people generally. Yes, there are sometimes even you'd want some advice from someone, all right, over an issue, all right. But when we're talking about depression and deep-seated depression, there are structured therapy models that are set out. There's cognitive behavioral therapy, there's interpersonal therapy. So sometimes when someone is, you can clearly see someone is referred to you and they're insisting on staying with their therapist who's been with them for 3 years. And you're like, okay, so what therapy have you been doing? They have no idea. Okay, could you go and ask your therapist what particular therapy are you doing? You find out eventually they just
Advice.
chat.
Oh, wanapiga tu
Some
story.
even meet in coffee shops and just chat. You know, okay, so a chat is good, but when you have moderate to severe illness,
You need a real.
you actually need
structure.
a real structured therapy model that actually, has objectives and it is time bound, such that if it gets to a certain number of sessions and you're not improving,
Dawa.
yes, it's either there's a problem with the diagnosis, there's a problem with the model, or there's a problem with the doctor-patient relationship, which is interfering with. Yes. So
You're saying currently there's a board. So like if I go to a therapist, I can look them up and see that they're certified.
Yes, they are certified counselors and psychologists. Board. So, and then also we have clinical psychologists and we have counseling psychologists, and they
those
do
are different.
yes. And I think we also have a group that calls themselves spiritual psychologists as well.
Hao ndio wazuri
We-
sasa.
we-
Nakuombea. Wekelea
Yeah.
mikono.
So, so the clinical psychologists have more inclination towards the scientific basis of illness. So they have a further
Ndio mambo ya
depth training.
serotonin.
They have a further depth training in terms of the different therapy models and all that, compared to counseling psychologists who offer more counseling services.
Okay. Interesting. Haya, what else?
But a good psychologist will not hold you in care.
If it's not
And
working.
they're seeing you're not improving, and it's been 3 months, it's been 4 months, you're not improving. If anything, you're getting worse, and they don't want, some
To
even
let
you
it
send
go.
the patients for a therapist and they tell the patients those medications stop them,
Yeah.
and you're wondering why are you trying to sabotage the patient's recovery journey? Is it so that you want
more
the
sessions?
yeah, and it's really selfish because there's a role for everything, right? And that's why
Unajua
we
hiyo
started.
2000 bana per session. That's a good money.
That was expense.
Yeah, that's good money.
Yeah, because you say
Ukitosheka na pesa ama patient asote
unamdischarge. Uko sawa sasa.
sasa enda umeze dawa.
so because when you said there's the biopsychosocial aspect to illness, there's the biological side, which is your genetics, which is illness and things like those, your physical health, etc., which can predispose you to a mental illness. There's the psychological aspect, which is things to do with self-esteem, if you've been through any kind of trauma and what psychological impact that trauma had on you. Then there's the social aspect, which is the environment around you. People who have grow up in environments that are probably harsh, whatever harsh looks like in different people's eyes, exposure to drugs, exposure to violence, etc. So all those are vulnerability risks for you to develop a mental illness. And when you have the illness, we try and look at all these aspects. What could be contributing to this depression that you're having? All right. As we said earlier, I could be battered at home every day, and I'm coming.
And meza
down. So even when we are now looking at the treatment approaches, we also now look at it from all the three angles. All right. There's the role for medication. Not all patients will get medication. There's a role for therapy. Not all patients will start with therapy initially. There are patients who need medication because a patient who's having hallucinations, you really can't have therapy. Okay. Yeah. Then there's a role also for the social aspect, because if you're having a drug addiction, you're not addressing the environment where you are in, or the same lady who's being battered, we're not addressing the environment where she's coming from. You're not going to change.
You're not going to change.
Yeah. So there's a role for all those.
Speaking of predisposing factors, the last episode we did with Dr. Mbiti. Dr. Mbiti is some very controversial guy on X. He's a doctor, and he's currently studying psychiatry. I may answer this year. And he was saying, he's a big advocate of the puff. Hiyo anasema, kwanza he was like, I am anti one term, but akilegalize hiyo anapewa 2 term. That was the punchline for that. Then, what do you think? Is there what is the role or what is the impact of drug abuse on the patients you see in mental health, be it depression, be it schizophrenia? Is there a correlation ama tuna force issues?
I think you've asked a number of questions in one. So I'll try to dissect as they are. So starting with cannabis, there has been a correlation with schizophrenia for patients who already have a vulnerability risk.
Oh, okay.
Right? So remember we said there's an aspect of genetics and all that. So there are people who are just naturally more predisposed to getting schizophrenia, or rather your threshold to getting schizophrenia is much lower than someone else. So inakwanga tu hapo ina chill, inangoja tu like just give me a trigger. Then you give it a trigger and we are
so
up
that's
and
like
running.
family history and stuff.
Family history, genetics, and
genetics even without a family history, like you genetically predisposed.
Yes. Most of the time there's a family history, but sometimes they're just spontaneous genetic mutations that can predispose you to that.
You see a lot of that because where I come from Rwanda huko watu wanakwamba wamepiga kitu mbaya sana. And then there's so many, like every day if you go there you'll see a new mad person.
There's always a new
there's
madman.
There's always a new one. But Daktari was saying in the podcast that there's different types of marijuana. Saying there's one that has not been shown to cause that at all. Is that true?
Yes, that's very true. So there are 3 types of metabolites. Yeah. And the one we have commonly within our setup is THC. And THC is what has been quite linked with psychosis. Right. So that's why we are seeing a lot of that in our setup. Now, the one we call medical marijuana is CBD. Yes. So with CBD, the probability or potential of it causing psychosis is low. And it's what is used as treatment for pain and seizure control in different nausea for patients who have cancer and Yes, so there's a role for medical marijuana. It's scientific, it has been done. However, when you come to our setup, okay, the problem would be legalizing without proper systems.
Yeah.
Because what will happen is we will have a very increased, sudden, all these people having access to marijuana everywhere. It is, sometimes when you make things illegal, okay, people are more curious and want to find it.
Yes.
But also, it makes it a bit harder to find
Exactly.
it.
Access
Becomes a bit difficult. And that's really because alcohol, right now, if you want to go and take alcohol, you just walk into the next supermarket and you'll find it. Or wines and spirits shop, whatever, in your local neighborhood, you'll find one. But if you're looking for heroin, utatafuta na utatafuta even
hata ukitafuta sana, even mwenye ako nayo atakwambia sina.
It starts becoming suspicious.
Mbona unatafuta hiyo? Mbona na ukai nikaa unatumianga?
So you see also that reduces accessibility to an extent, to a slight extent, which is a good thing, especially protecting the young brain, because a number of people try drugs when they are in their late adolescent years, and at this point is where the brain is undergoing a lot of synaptic connections, and your brain is basically deciding what is important, what is not important. What is important, we keep. What is not important and not utilized, that one we discard. So you find you're focusing a lot now on the drug. Your brain now knows, so this is what we are focusing on. You neglect school, you neglect using parts of your brain that of creativity, cognitive functioning. So your brain is like, okay, so we don't need that, get rid of that. Right? So those connections are not strengthened as they would be because something else is taking over. Yes. On its expense.
The brain must be very interesting.
Very.
Lakini mapedi mmesikia CBT. Unajua sasa mapedi wataanza kusema sasa hii yangu mtu wangu hii ni CBT. Nikikupea CBT.
You see, even when we are doing testing drugs of abuse, when people are abusing drugs, when you go for a drug screen, we don't test cannabis as a whole. We test THC. Because that is
eliminated marijuana.
You need a lab for that. You see, so and then for whatever reason, the scientific studies that have done, our cannabis around this region is predominantly the component is predominantly THC. So
mapedi asituchoche. Unajua unakuwa na maforeign. Foreign.
You know what I say? It's all fun and games
until
you land in Madare.
Yeah.
I normally tell people, just go have a visit there.
Yeah.
I don't know if the times have changed. Maybe things have changed now. But while I was doing my training, close to 70-80% of the patients there.
Drug-induced?
Drug-induced.
What about alcohol?
Yes, alcohol. We talk. It's usually made like such a light thing. Yeah. See, yeah, but alcohol use disorders. Alcohol has destroyed families. It has destroyed livelihoods. It's destroyed people's futures. So, yes, alcohol is also another silent enemy that,
Hey, it's bad. We were with Dr. Prakash the other day, and he's the med super at Nairobi West. And I used to work there, and oh my God, there was a ward. And it was just AUD. And those guys are kwanza ni macops, man.
Yes.
Macops. Oh my God. You're like, you guys, how do you work? Na even ndio mko. So, I don't know. Is it a menace in Kisumu as well? How bad is it?
I think the highest level, according to Nakada, I think is in Western Vihiga.
Vihiga.
I think if I'm not wrong, I hope I'm not quoting them wrongly. It's a county in Western, and I suspect it's Vihiga from the last Nakada report. And
it could be true.
Particularly Changa. Yeah, particularly Changa, the illicit brew. It's quite, it's
You know how it is in Vihiga. Vihiga have a lot of valleys, iko hivi, the landscape. So you find that in every kavali
kuna
kuna
kachuo.
kachuo. Kisonga down kuna kengine. Yeah, and then there's no land. Guys are idle there. Guys, they're young, energetic, and idle.
True.
So Omosala and
Ndio masala.
it's a lot there. It's a lot
Yeah.
there.
So yes, Kisumu still has levels. There are enough places that are usually changa dens as well.
In Kisumu,
Yes,
the city of the county.
but
Allah. Happy boat. Interesting. Allah.
yeah. So they are, but as you said, Western takes the
Carries the day.
takes the trophy home.
Wameshinda Moranga though. Ama Moranga Rigiji alisaidia when he was DP.
In terms of alcohol use,
Yeah,
it was a
addiction.
Western county.
Really?
It was, I think it was at 11, prevalence was about 11%, if I'm not wrong.
Dr. Mbiti said that if he hadn't started any of those things, he wouldn't start right now, knowing what he knows. What would you advise the young guy there who just wants to experiment from a psychiatrist?
I'd advise the same because see, even the patients who are seeing in Madare with all these drug-induced disorders, you know what we'll tell them? Sometimes they're in there for, or even let's say you go for rehab. It gets so bad you go for rehab. You're in there for 3 months, all right? Okay, most rehabs don't allow visitation, which is different. But spaces like Madare, you've been admitted, let's say, for drug-induced psychosis, for example. Those friends, they're nowhere to be seen. Who comes to see you every other week? Your mother, your father, your sister, you know, your son, your daughter. Those are the people. Your friends, the ones you were drinking with, nowhere to be seen. Then you get discharged like this. They're like, Morio
Umerudi, champe, pea.
You know, and we
Walidhani
welcome you.
utatoka, umetoka.
Yeah, they're like, now for that, kuja to celebrate. Pewa mbili. You know, and they return you back to the same
Does rehab work? Because just the other day, Nani died, Kimani Mbogo, and he's been in rehab several times, sponsored by Mike Sonko. Does it work? And I've seen people go to rehab several times and come back and go back. Does it work?
So
because there's an argument that these rehabs have been made into businesses.
They are, and there are many that have been turned into that. Now, the thing about rehabilitation, from my perspective, is whenever we force a patient to go to a rehab, okay, they've not come to the conclusion that I'm ready for change. They've not come to that space. They've not come to that. So they're there to pass the time. So you want me here for 3 months? I actually had a patient who told the parents, you want me to go in for 3 months? I said, 3 months will end and I'll be out. All right? So for them, they do it either...
pressure from society.
Yes, because I'm a child and I've been told by my parents I need to go for rehab, or I'm doing it because nyinyi mnataka niende rehab.
But them, they don't want it.
Nitaenda. Sawa. You know, or they go to rehab because you've been told, ukishamaliza rehab, nakufungulia biashara. Okay, and they're like, yes, and I need that money. Okay? So there's no real motivation for change. So personally, I don't advocate for forceful rehabilitation. Rather, we start with, there's a particular type of therapy that usually tries to get you to a space of change. And for the change to actually stem from within. And if you look at the model of Madare, for example, patients used to come for an outpatient clinic every week. Once they were ready, you're assessed, now you're ready for rehab, is now when you get into the rehab program. And you know how rehabs, you know, usually closed off, you know, no phones allowed, sijui mmefungiwa kufungiwa kabisa. Those ones, the patients are allowed to, you know, they're a bit more free compared to, and the thing is, you're there because you want to be there. You know why you're there. it is yourself. And if you abscond, I don't know if that's the rule till now, but I think that was the rule then, or it was a rumor. If you abscond, they never take you back. Hiyo ni usiairudi. Wewe ukitoka, we toka ka umeenda.
Yeah, madhara.
Because the queue was so long, but the success rate was also very good. Because people are coming in because they know why they're coming there. What are they coming to do? I'm coming to reform. There's this alcohol, there's this cannabis that has taken over my life. It has, distorted my family. It has distorted my job. I've become
useless,
for lack of a better word, not my word. So they are ready for change, and they're willing to take that path. Of course, that doesn't negate the possibility of a relapse. There's still that, because we're only human, but it's reduced compared to the other people who are discharged from rehab. Now you to that same day, they're like, "Boss, this is the moment I've been waiting for. Finally, you've allowed me to go. Let me go back to my den." And that same night that you've discharged them, they don't even reach home. Yeah, those things they had, they throw them somewhere.
Ingia kwa den.
Anaingia kwa den.
Piga moja mbili.
Mbili, and then now the problem with that is you'd starved your body for so long. So the rule
tolerance
of,
is a bit low.
Yes, and the rule of extinction. So, because your body had already been primed, so it just needs not as much as the last time. So you find before unge rehab, you are taking maybe a whole quarter mzinga, unamaliza mzima peke yako. You find this time your receptors are just there waiting. Ziko hivi, ziko rada. Yeah, so you find you just take not as much as you would before, and I mean they're back. Yeah, because they've already been primed.
Well, normal. So these rehabs, should they be regulated by you guys?
They're usually regulated, yes, by NACADA. And if you go to the NACADA website, there's actually a list of rehabs that are actually approved.
There are others that are not?
There are very many that are not.
We won't go into that.
The question is why they're not closed. Exactly. That's a different
hiyo ni Kenya. Hiyo ni Kenya.
Kuna vile vitu endanga. But yes, there is the website. They have a list of which rehabilitation centers are
amazing. Anyway, time is not on our side. So as we wind up, this podcast is usually from addicts mainly, but also other people, as you've seen. Yeah? So, what dear addicts, young doctors, even a bit older ones alike, have really been victims of depression, and more than enough have taken their lives through suicide. I don't know, you as one who has been through the system, the whole of it, I might say, unaweza ambia nini hawa vijana mazee wenye tukikosa CBA kidogo tunaamua to hell with this?
I think it's more of building more resilience. And why I say more resilience is because as times change, things become harder. Yeah, because the kind of life that was there for doctors 10 years, 20 years ago is not the same. Before then you knew, like, for me, when we were in school, you were guaranteed that by the time you finish school, there'd be a job.
Sure.
Right? It's not the same situation as we speak. Right? So it's just growing more resilience. And another thing is also widening your options. Yeah, we've been too stuck on what is normal, what is expected. Yeah, but you can widen. Right now, there's so many things you can still do as a doctor. All right, within the medical space, we have doctors who are venturing into other fields as well, like law, and now becoming medical legal experts, because they have now both the knowledge in law as well as medicine, which puts them at an upper hand. Yeah. We have usually not an advocate for brain drain, but I mean, you've asked me to advise younger medics. I'm not advising them, I'm advising younger medics. You know, if it gets to a point, you know, you've tried what you have, but you are coming to a society that doesn't really appreciate you and is leaving you out. And you've seen people who have degrees and going to sell tomatoes, you know, and mtumba iko na biashara we. But anyway, najua hata mimi nilikuwa nauza.
Ulikuwa unauza mtoshi?
Mimi hustler. So back in the day. But you know, so you get someone who's resulted to that because there's no other option. You know, and they have nights where they sleep hungry, right? Having gone through the whole six let
7
me
years,
just say trauma of medical school
trauma.
for lack of a better word. Having gone through all that experience, you know, and just, I mean, if there are opportunities that come out there, go for them.
Go for them.
Go for them. The thing is, you want to be appreciated in a system that's probably not as grateful as you think they would be. Be a bit more selfish as well, because at the end of the day, everyone thinks for themselves first. Yeah.
Mmesikia hiyo maneno? Be selfish. A
Just be
bit.
selfish.
Not too much. A bit. Daktari, I mean, thank you. Thank you very much for the wise advice at the end, and thanks for making the time. I mean, it's been amazing. Been very educative and very interactive. I have enjoyed this session. It's the marijuana session. So, I don't know, any other thing?
No, you know, when we started, I kept saying, hey, look here, I just, disclaimer. I've been a doctor for, this is going to be my 11th year.
Wow.
I've been a psychiatrist for, it's my 6th year.
God damn.
Yeah. When there are people who look at you and they're like, huyo bado ni mtoto. Yeah, they call me the Gen Z psychiatrist. Hello, Gen Zs, yo. They say I was born maybe prematurely.
But hiyo ndio poa. Sasa unapata clients wengi. By the way, is there do you get some sort of that from patients, like, hey, you're too young to be?
A lot. But the thing is, you know, when your work speaks for you, watch up here. Saa zingine unajiona
jichoche mtu wangu, jichoche sema,
So,
ma schizophrenia zinapona huku nje.
Yeah, so whoever becomes the marketer is the patient, who recovers, and they bring in the other one. So you know, when you talk to patients on phone, they're like, okay, and then they come and meet you in person, they're like, okay, we're looking for the doctor. You know, and you're like, yeah, I'm here, what's the issue? No, tunangoja, si hatuna shida, tutangoja tu, tuliambiwa daktari atakuja. You're like, no, mimi nimefika. They're like, and you can clearly see, like, okay, but then the fact that they've been referred by someone else, they're like, okay, let me take a sip. Can I take a shot? I'm like, okay, sawa. But then sometimes you just have patients who just tell you you're too young. Especially the older men. They'll tell you you're too young to listen to my problems because you're the daughter. When I look at you, you look like my daughter. And you're the age of my daughter. And I prefer an older psychiatrist. And they're right. Yes, because the same breath, there are patients who go to a psychiatrist and be like, hey, these mbabes, you know, and they're like, can I have a younger doctor who may understand me a bit better?
Issues zangu ni, I'm depressed because I don't have IG followers.
Yeah, I don't have likes, sina likes za kutosha, watanielewa, you know. So it cuts across. I mean, there are patients who will not want you because you're young, and there are patients who will want you because you're younger.
True. I get a lot of that because I'm skinny. People think I'm too young.
Yes, that's the other thing. Shida kukua mtu mdogo.
Mazi.
Na shida ukijaribu kuona.
Lakini ukiona daktari yako na kitambi,
bas.
Ndio anajua.
Yes, and you know, the funny thing is, also bring this perspective, being a female as well. There's usually, particularly in the peripheral regions, because I didn't experience much of this while I was working in Nairobi, more now when I started working peripherally. Being a female, you find people just come, they're like, sister,
Okay.
you know.
Does that annoy you?
Initially it used to. So I told you, stress, block you. You create a
A wall.
barrier across your heart. So people will say all these things. And then the other thing is our patients even abuse us sometimes when they're in manic episodes. They say all manner of things. So if you take these things to heart, you
But I was to ask you, have you ever been attacked by a patient? Physically. Ushaiokotwa videvu. Pam pam. Bado.
Story for another day.
Sorry for another day. That
But
means yes.
there was a patient. I used to work with one of the top psychiatrists in Nairobi. So he left me his clinic. Then this patient walks in, and his brother walked in without his mother. So he was like, "Let me go get his mother. She's the one who knows more about him." He leaves me in the room with the patient. And the patient just wakes up. He's like, hey, leo utanijua. You know, and then he's uttering words I can't say for viewer discretion. And I'm like, whoa, you know, and he's approaching me. Oh, I'm like, okay. He starts removing his shirt. I'm like, yo, you know, so I called the emergency.
Oh, you had the emergency bell.
Yeah, then, of course, the secretary came in, the mother and the brother had already found it. Was like, my God, Lord, dear Lord
died.
Jesus. You know, he was being very vulgar. You know, it's just, wow. You're like, yeah. But yeah, it's so being a female, people tend to look at you and they're like, sister, nurse, you know. And funny thing is, you'll find you're there with a male nurse, then they'll call you sister, and then now that is the doctor. You know, there's still a lot of that notion, and the fact, you know, you could be more experienced than an older doctor, but you're who's male, but you're female, you're young. No, huyu mwenye akona nywele ya white, huyu ndio anajua, huyu ndio tunaamini. Yeah, even when they're being mismanaged. So, but at least the good thing in this era of being woke, people are a bit more aware. People have this information everywhere, so that's all I tell my patients. There's nothing I'm hiding. You can go check this information. It's out there for you. You can go read. You can go confirm. If you have any questions to ask me. You know, it's not I am the doctor, take this medication. Like, no, these are the options we have. What's your take? And then they'll tell you, no, you're the doctor, decide for me. Like, okay, so as the doctor, for me, what I'd choose for you is this and this. Do we proceed? You know, so we're moving more towards a space where it's more patient autonomy.
Patient-centered, patient-directed.
Yes, rather than I am the doctor, I have said, and do as I say. When I say jump, how high?
Jump.
Yeah, I think that's,
amazing. So from Daktari, a quick one, it's been more than an hour of just Dr. Linda Nyamute here. Nyamute is a kissing name? This is not a tribal.
Daima mimi Kenya.
Mwananchi mzalendo. But we say our pride is our diversity is our pride. But hatutasema. Daktari hataki kusema. So from Daktari, a quick one. Hata wewe homework. Tell me the comment section. What do you think? Where do you think Daktari is from in this Kenya? Amesema yawa. Labda ni mtu Alexide. Anyway, from Daktari, a quick one. Opulence. Okay.
Don't quote me.
Anyway, Daktari, thank you for coming. And adios. Kama kawaida, and by the way, before we close, Daktari has been nominated to top Daktari Awards from her work on TikTok in mental advocacy. She's also on YouTube apparently. Go check her out and go to Top Daktari Awards. Just search Top Daktari Awards or Daktari, a quick one, whichever one inaku nice. Go to vote. Scroll down, mental health advocate of the year. Dr. Nyamute is right there. Click vote and vote for others as well. Okay. When she wins, tutamletea hapa trophy. We'll celebrate. We'll say yay. She keeps up the good work, and you too can be nominated next time. So keep it up. From Daktari, a quick one. Adios.